And thank you very much for joining us once again here on PM Express. And then, of course, this is a night, it's a pretty rainy night, very wet night. But health experts are racking their brains around the detection of the Indian strain, the Delta strain in this country. Of course, today there's some good news that finally Ghana get to contribute its own quota in the global set for solutions to COVID-19, which is that we are beginning clinical trials in Ghana for 2 separate vaccines that if we go through with it and are successful, we might be front of the queue, possibly, in getting access to those vaccines, because COVID is going to be with us for a very long, long time. But our immediate concern is the detection of this. And we're going to be having a conversation about, does this require a change in strategy? What next must we do to avoid what is happening in India and currently what is happening in the UK? Let's go through what we know for you tonight on this all-important matter. We were told just this week by the WAPIC, the West Africa Center for Cell Biology and Infectious Pathogens, that they have detected the presence of the Delta strain in Ghana. They do the sequencing, and in that they found that that particular strain is here. They say it originated, obviously we know this from India, and is currently the most dangerous strain across the globe. More infectious, more contagious, they've spelled out. When you talk about danger, it relates mostly to those who are still not vaccinated, that it can kill you quicker. And so that is so important when it puts the vaccination campaign into some perspective for us, as far as this is concerned. But we're also being told that the Delta strain, apart from it being in Ghana, thankfully, we don't have it in the communities. No, we don't have community spread yet. That has to be emphasized. The question to ask tonight is, how do we keep it like this? How do we keep it just at the detection at the borders? How do we keep it at the borders and not get it to spread among the communities? A key question we'll be exploring tonight. Because also WAPIC told us that the detection was made fundamentally at the point of entry, the Kotoka International Airport. So when you pick it up there, it is easier to deal with it. But also remember that coronavirus came through the same channels, and yet it has become an issue in Ghana. Have we learned our lessons? Because trust me, you don't want that Indian strain taking hold in Ghana, because that will be devastating, especially when there's a prediction of a 3rd wave coming. Now, we need to intensify border checks. Is one of the key things that has been suggested as part of the solutions to this. WHO has concerns, right? They classify the Delta strain as a variant of global concern. That's the WHO. Delta has moved from a variant of interest to a variant of concern. When the WHO begins to label a particular disease as that, it raises it above what we know as a traditional normal coronavirus, right? Number of strains in Ghana currently, again, according to WAPIC, is 45. And so as we sequence, we get to pick up more. And these are just a manifestation of the mutations, okay, of the virus as it keeps spreading. The best way to stop the virus from mutating into a Delta strain or whatever strain is to stop the spread. And that is why wearing of the face mask is absolutely critical, and washing your hands is still very important, even if you've been vaccinated like I have with 2 doses. Now, why the name Delta? Very important point to learn the basics of this. Alpha is the UK, Beta is the South Africa one. We have the Gamma is the Brazil one, Delta is the Indian one. And so they find a name for it just to distinguish these various variants. I've had an argument to say that we found the South African strain in Ghana, it still hasn't become the dominant one. But the question to ask on the back of that is, are we sequencing enough? Okay, because that's where you begin to know which one is the dominant and which one is not. Are we sequencing enough? That is a big question we'll be asking tonight when we speak to our guests on this. Now, Delta is fast becoming the most worrisome of the lot. At least 60% more transmissible than the Alpha strain. It has spread in more than 80 countries across the globe and still, leaving its trail wherever it goes. Now, there's a big question that we'll start with tonight. and it relates to the Delta strain and the vaccines that we have currently. Do the vaccines we have currently, are they efficacious and potent against it? It's a big conversation that we need to explore, because there are some who believe that the vaccines that we currently deployed in Ghana, Sputnik and AstraZeneca, are not as potent. And so in the changing of the strategy, we should be looking at different types of vaccines. Other experts disagree with that, and I've seen research work actually backing that, that school of thought, that in fact, the AstraZeneca and the of course, the Sputnik V are still very potent. However, look at what the statistics say. AstraZeneca is 60%, and Pfizer BioNTech is 88%. And so, of course, I mean, you rather have this than this. But if you have AstraZeneca, you're also okay. I mean, it prevents still serious infections or more devastating outcomes, right? The UK is currently struggling with Delta. Why? Because they were almost about reopening the economy, and then they found that Delta has taken a grip. They did a sensible thing. They called off the reopening so we can focus on dealing with Delta, right? Which is now key. The most dominant in the UK, accounting for 90% of the cases. And I'm happy that tonight we'll speak to somebody, an expert in the field, who is joining us from there in the UK. Of the 42 deaths in people with Delta variant infections in the UK, 23 of them were unvaccinated. So paying attention to that. 7 had received only 1 dose. 12 had received 2 doses more than 2 weeks before. So this for me is worrying, right? 12 of them had received 2 doses more than 2 weeks before, and they still got infected with the Delta, and it caused fatality. I mean, so for me, that clearly is an issue for me. I mean, we'll get to the experts to weigh in on that once we sit down. Pay attention to this. It's important. Don't take the COVID protocols for granted. We'll look into that. Now, the WHO has requested the US to send 30 million COVID vaccines to Zambia, Angola, and Zimbabwe, and we are also struggling for our share. The number of deaths is doubling, as we know now, every week in some countries, such as Zambia, where they're experiencing, from what I've heard, a third wave. And there's been predicted that we might also approaching our third wave in Ghana. So this needs to be explored in greater detail. But I have even more worrying news. Just before I came on, I've just been reading from India that they've actually found another mutation of the Delta variant. They're calling the Delta Plus. What is that? My expert panel know all about this. The Delta Plus. That is even more, I guess, potentially more infectious and deadly. And so listen, we are way off from solving this problem. Should we be closing our borders when it comes to places like India, now that they've detected another mutation of the Delta? Stay with me. After this break, we'll get into that and get the answers for you. And thank you very much for joining us here on PM Express. I'm delighted that you could stay. This is a very important conversation. Your life may depend on it. And thankfully, I have the experts to help us navigate this. One of the key things I believe we can do as journalists, together with the experts, is always to help you navigate this field of COVID, especially as it unfolds and develops, so you know what the latest information is, so you can protect yourself. And that is why I'm happy that they've been so good since this started, helping the public, laymen like ourselves, walk through this maze of the COVID virus. And I'm delighted to say, as always, the indefatigable pharmacist and CDD fellow in health, Dr. Kwame Asiedu-Sapon, joins us. He joins us from the United Kingdom, where obviously they are having to deal with this the Delta strain. And I'm pretty sure he was looking forward to the economy opening up so he can enjoy the rare British sunshine. He's not going to have exactly that yet because of Delta. John Amwesi is also joining me. Always happy to have him on the show. Leader Global Health and Infectious Diseases Research Group at the KCCR. By the way, I just learned today that KCCR is one of the centers for a new clinical trial for a vaccine, which is interesting. And I'll pick their brain on that as well. He's also a lecturer, Global Health Department at KNUST. Oh, and also, I'm happy to say that Dr. Yao Bediako, he is with the West Africa Center for Cell Biology of Infectious Pathogens, University of Ghana. And his boss had told us about the detection of the Delta strain. And so I'm happy that he can join us. Dr. Yao, thank you again. Always a pleasure to have you join me. Also, Dr. Ibrahim Odro is head of research at the Ghana Health Service. Dr. Ibrahim Odro is head of research at the Ghana Health Service. Remember, a lot of the conversations will come to nothing if the Ghana Health Service doesn't pick up on it. It's good to also test what you're thinking as we move forward. I mean, gentlemen, I want to start with you, Kwame, because of what I just read before I came on. I'm reading that in India, they found this new mutation called Delta Plus. I mean, what is that? I mean, and how worried should we be now that we already have the other strain here?
Thanks, Evans. Good evening to my colleague panelists, and good evening to listeners and viewers. Evans, the truth of the matter is, anytime I'm asked how worried should we be, the simple answer I give is as worried as we've been from the start of this pandemic. And I'll tell you why. In a country where vaccine coverage is low, our best bet is protocols. And therefore, the wearing of face masks, social distances, avoiding of crowds, hand sanitizing are the best bets. The next thing for me is the current data coming from the UK. And I must say that the data is so fluid. Because I work in this sector, I'm fortunate to have received the latest data tonight, so I can speak to that. And you'd realize that there are two things going on. Like you rightly said, the Delta variant is on the rise, but in specific population segments and in specific areas. It's on the rise in the population segment below the age of 24 who haven't been vaccinated, and people above 24 who refuse to take the vaccine. That is key. The second thing is hospitalization is highest in people who haven't received the vaccine. And I'd want to address one thing quickly that you put up when it comes to mortalities. Of the 12 mortalities that you talk of that had 2 shots of the vaccines and 2 weeks after, there's a 3-way split between Pfizer, Moderna, and AstraZeneca. In fact, of the 12, only 2 are known to have had AstraZeneca and have passed away. The data is still out as to whether the cause, because of the age segmentation and the fact that 6 of them also had immunocompromised disease, which then brings in the question of what was the extent of their immune response when they received the vaccines. I have decided to situate these because they are important, and the likes of Dr. John Amoesi and Yao would speak to the science, immunology, virology when it comes to that. But they are very, very important. But what you realize is that as case loads are going up in the UK now because of the Delta variant, hospitalization is not going up. And in fact, mortality is dropping. As of today, mortality is its lowest. It's as low as it was in August of last year, which is very poignant. So, and then you look at the current data, which says that after the second dose, the Pfizer vaccine is 96% effective at preventing hospitalization. AstraZeneca is 92% effective. When it comes to symptomatic disease, which is even if you get infected, would you show symptoms, after 2 doses, Pfizer is 85% effective at preventing symptomatic disease, and AstraZeneca is 81% effective. So on that basis, the vaccines are still working, albeit there's been a median drop, which I mean average between the two, of about 9% in their effectiveness against the original variant. Anyone who works in this sector will tell you that that's understandable. You wouldn't design a vaccine for one flu strain and expect it to go along because of mutations. So that for me is not a problem. As long as you have enough people vaccinated, and that was why UK pulled back, opening up from the 19th of June to accelerate vaccination in people within the ages of 18 and 24, at least to get them 1 dose each, so that by the 19th of July, they can open up. In fact, based on today's data, politicians have been toying with opening up on the 5th of July. That is how dynamic and fluid the situation is. And so if you ask me, based on the new variant, what is the thinking? The thinking doesn't really change. As long as we comply with the protocols and as long as we can accelerate global vaccination.
Okay.
The point is, nobody is safe until the globe is closer to herd immunity.
I mean, Dr. Amoisi, let me bring you in. And he started by talking about the vaccine situation. I mean, there was a suggestion that now that Delta is here, it's possible that in changing the strategy, we also change the vaccine strategy too, and focus on other vaccines other than AstraZeneca and Sputnik V. Is that something that you endorse?
Well, thanks, Evans, and good evening to Kwame, to Yao, and to Abraham who are joining us, and to everyone who's listening. To go straight to the point, I think Kwame has really nailed it very, very clearly. I'll answer your question very directly and explain my answer afterwards, which is no, I don't think there's any need at this stage to change the kinds of vaccines that we're using because of what we're seeing currently. I'll explain. The reason is it always depends on what you're actually measuring. And I think I've touted this over and over again anytime I've had the opportunity, which is, what are you measuring? Are you measuring infection rates? Are you measuring hospitalization rates? Are you measuring mortality rates? These are very, shall I say, similar, but also very different markers of a disease or the success of your prevention and control strategies, which need to be appreciated in very separate ways. If you look at the ultimate aim of the vaccination, or what we really want to avoid, it is death, all right? Now, beyond death, you also certainly want to reduce your hospitalization rates, and ultimately you want to reduce your infection rates. Kwame has very correctly laid out what the current real-world data, and that's a technical term that is used, real-world data is showing us. Now, real-world data is so powerful, much more powerful than you would get in typical sterile clinical trial situations. But there's one thing about real-world data. It is real world, which world? So far, it's the UK. But if the data is anything to go by, we realize that whatever pertains in other parts of the world tends to also show up here. We saw a first wave, it came here. There was a second wave, we had it as well. And we can clearly see that we are somewhat in the beginning of a third wave of sorts. How far it will mount, we cannot tell. But in other African countries, it's already going up. So coming back to the issue of the vaccination, the AstraZeneca vaccine has been clearly shown to reduce infection rates, including for the Delta variant, albeit to a lower extent than some of the other vaccines. But the key thing here is severe disease and hospitalization. And you're actually seeing the AstraZeneca giving you a decrease in hospitalization by 86% for the Alpha variant, which is the Kent or the UK variant, and up to about 92%, as Kwame stated, for the Delta variant. So it's really interesting that the Delta variant is actually more infectious. It spreads faster than the Alpha variant. And yet the AstraZeneca vaccine reduces hospitalizations to a larger extent than it does for the Alpha variant. It just tells you the power of vaccination. Now, the Delta variant is spreading all over the world. In fact, currently in the US, as of today, almost 21% of all their cases are from the Delta variant, and it's going up. Our numbers here, I do not know, and I'm sure we cannot really put a finger on it because we do not have the Sentinel system in place to measure real time what we have in our country. We have something in place, and we know that we have the Delta variant in country, at least this has been detected in the airports, but we cannot apportion the variants in our current population, right? So when you have this kind of data, realizing that the Delta variant is spreading, it's occupying a larger percentage, and yet, even though it spreads faster, the reduction in hospitalization rates is actually higher with the AstraZeneca vaccine for the Delta variant than the other variants. It tells you that we're actually in a fairly good place by using the AstraZeneca vaccine. But the question is, how many have had 2 doses? All right, how many have been vaccinated at all? And how soon will we be able to vaccinate as many people as possible? So it's about the vaccination and about the speed thereof. And from what I see or what I have gathered, just interviewing and random data here and there, the vaccine acceptability levels are alarmingly low in Ghana, alarmingly low. You wouldn't like to know. And so I'm very concerned. Beyond the government bringing in the vaccines, I'm really concerned as to whether people will take them to the level to which we can achieve the proverbial herd immunity, which we need so badly if we want to come out of this. Yeah. And the Delta variant won't be the last. There'll be other variants coming up. We already know the Delta Plus, which you rightly mentioned. Of course, it's now just a variant that has been identified. Not much is known about it, but there will be others. And until we vaccinate, we won't have that effect that we need. In the UK already, they're seeing clearly that they had a high level of vaccination. And so when the Delta variant appeared, it did not in as much as cause a blip in their mortality figures. In fact, the mortality figures are going low. So the infection rates may be going up, but the mortality numbers are going down. And that's what we would like to see in Ghana. So the key really is vaccination, vaccination, vaccination.
Yeah, I mean, Dr. Bediako, your institution detected this. Did it come with a recommendation on, okay, so we found this, something must change? I mean, what's your own take on that from a scientific expert point of view?
I agree with my 2 colleagues who've spoken previously. The sequencing is meant to be a surveillance tool. Sequencing gives you an idea of what is circulating and many of us have been saying that we needed to sequence as much as we can because you don't just simply testing doesn't tell you what variant. You just know that people are positive or negative. In finding the Delta variant, it's not surprising. A Delta variant is rapidly outpacing other variants in the UK. It's rapidly outpacing other variants in the US. We have found, even in East Africa, Uganda has a huge wave, a huge surge due to the Delta variant. Western Kenya right now is having a similar thing. So it was not surprising that we would eventually find the Delta variant. So far, thankfully, these are samples that were collected at the airport. Now, these were samples, I believe, taken in April. So now we are in June. We've done some sequencing on samples in May from the community. We did not find the Delta variant, but those were about 300 samples, right? So you have to take this in context. If you are sampling 300, we have how many people in this country? We have 30 million people. Let's say you have an average, we are saying our test positivity rates are hovering between 5 and 7%. Every day, at least 1,000, probably I think 2,000-3,000 tests are done in this country. Now we could argue whether that's enough testing, but still, if for a whole month we only sequence 300, and we've done 3,000 times 30, so we've done something like 30,000 tests, then 300 is a very small sample. So that is a problem that we have, is that if we haven't found it, it's encouraging, certainly, because if it was in very, very high numbers, we might find it. But we're also not sequencing enough. So we need to increase the amount of sequencing. The sequencing so far is largely funded by grants. The money that is coming for sequencing, the government has contributed some money to support some of the sequencing of the airport samples. But all the community sampling is largely funded by grants from our academic institutions. So that limits sequencing is not cheap. Doing 100 samples is going to cost you $10,000. So this requires significant outlay, but it's extremely important, because if we want to hang our hat and say Delta variant is not circulating in Ghana, then we have to sequence more than 300 samples in a month. The UK, for example, sequences well over 1,000 samples a week. The UK has contributed more sequencing to the global sequence for SARS-CoV-2 sequence than any other country. And that is why the UK is always able to detect new variants as soon as they emerge, because they're doing much better than the US, for instance, in identifying new variants, because they are sequencing at such a high clip. So, Ghana in total has sequenced maybe 650, maybe if we include, WACBIP, we've done about 630, 640. I think we have another couple hundred under analysis. I know Noguchi has done a few hundred, a few other places. So I don't think Ghana has yet done 1,000 sequences as a country. The UK does 1,000 in a week. So I think now that there is this attention being drawn to these variants of concern, I think it emphasizes that our approach needs to continue in terms of vaccinate. The vaccines are still proving to be somewhat effective. In terms of symptomatic disease, I think, AstraZeneca, I think actually it's closer to, 60% for symptomatic. I think for hospitalization, it is around 83, as Kwame has said, because under normal circumstances against the Alpha variant, for symptomatic disease, AstraZeneca was only around 75%. So I don't think it can be 83%. I think today AstraZeneca themselves came out and said, they're looking around 60%. But that is still a pretty good vaccine. So we need to vaccinate, but it is 2 doses, as Dr. Amuesi has said. A single dose of Pfizer doesn't seem to do very well against against Delta. It looks to be around 30%. You need 2 doses. And so the urgency has to be, we need to vaccinate as many people in Ghana as possible, as quickly as possible. We have to get second doses to those who have not yet received second doses. Yeah. But at the same time, from a surveillance standpoint, we have to increase the throughput of sequencing so that we get a much clearer, much more accurate picture of what is truly circulating. Because it is possible that there may be variants circulating, there may be variants of concern circulating in Ghana that we have just not identified because we haven't sequenced enough samples. Yeah. So that is, that from our perspective as sequencing, it is, it's good that we have the capacity. No one has to come and sequence for Ghana. Ghana has the capacity to sequence. We just need adequate resources to increase the number of sequences that we do every week, so that we can be more confident that we are actually detecting what variants are circulating.
Thankfully, we have Dr. Ibrahim Odro, head of research at the Ghana Health Service, with us. Doc, so since WAPIC alerted Ghana Health Service about the Delta strain, has it been business as usual, or something has actually changed in terms of the approach? We've heard that more testing, more sequencing, more vaccinations is the approach, of course, protocols. What has been the approach since we learnt about the presence of Delta? Can you unmute for me, please?
Yes,
Dr. Yes, thanks, I can hear you. Yes.
My greetings to Kwame, Bediako, and Amosi. I guess nothing has changed yet. Like you said, the virus, as we all know, will continue to be under pressure. So as we move forward, we'll continue to get variants. It's not like we'll have one variant for life, because the virus, once we are intervening, will continue to be under pressure. So going forward, we're going to get variants up to what number we can think of. But as to whether those variants will be of public health importance is what I guess they've all been discussing. Yes. It's possible you can have variants that are fine. They theoretically may be not sensitive to the available vaccines, but when the vaccines are deployed in the field, they will still be effective, because it's not just 1+1 situation as it is, because you give the vaccine, there are other factors that come into play before the thing works. And like I said, so we in the Ghana Health Service, I'm in the research, the public health also, but we'll continue to do what we are doing. I guess that's for, like before I said, the most important thing is to continue with our preventive measures, because the key issue is that if you're able to prevent the virus from getting into our country in the first place, there will no need even to get a new vaccine. So the key thing is to be able to focus much more on our the existing preventing protocols. The fear is that as we try to confuse the public also much with the variants not being sensitive to this, that itself would also, to some extent, to also be worsening the vaccine hesitancy that was initially said. So Ghana Health Service hasn't changed anything yet. Ghana Health Service is monitoring the situation, like the Director of Public Health said a few days back, is that they are enforcing the screening at the airports and the points of entry and making sure that anybody who gets there is properly screened. And if they are found to be positive for this new variant or the existing variants, they will monitor them very well and ensure that they are, we don't get the new variants into our community. And so what's probably I'll end up by saying is that service still maintains what it is. A service is still encouraging everybody to continue the preventive measures. Service is still continue to treat those who have the diseases, and we will continue to enforce our surveillance. And then we encourage work with our stakeholders like MOC, and particularly with WABIC, who are doing the sequencing, so that any other new variants that come back, we will be observing it and also be studying the global situation and see when there's the need for a change, that change will come. But for now, I guess the key issue is the status quo will remain.
Yeah, okay, so status quo remain. But let me ask you, in other countries like the UK, they've developed this color coding system for countries. So they have what they call the red list countries, in which you have India. When you arrive from a red list country, you are treated differently from other color coded countries. I mean, isn't it time we adopt to that? Especially now we are learning today that there is a Delta plus. I mean, that can possibly be even more dangerous. Should we change our approach towards arrivals from countries? Now everybody else can arrive, right? And we test them. Should we change our approach at the ports?
Yes, I guess the approach is not static, it's fluid. And in epidemiology and public health, as we are observing the global situation, as and when we know that there's a resurgence in India or in UK, those coming from those places, there'll be a special eye on those people so that we'll look at them. But you should also know that we are not endowed like UK and other countries that we can easily change approach every now and then. So I guess those suggestions will always be taken on board, and then with those coming from those high risk countries, there will be special eye on those people, and the priority will be given to those people in terms of screening and testing.
Dr. Kwame Asiedu, what's your take on that? Because our biggest threat is from the ports, right? I mean, how should we approach that?
Well, it's interesting. I think I agree with Abraham, and I'll tell you what. If you look at the UK specifically, and you look at the traffic light system, it was designed for a particular purpose, and you need to go back to the UK's COVID strategy to understand the purpose. Initially, UK didn't even do anything at its borders, because the emphasis was to find a vaccine. And like Yao has said, because they were sequencing to be able to identify the different variants and to design a vaccine that was susceptible to these variants. Now that the vaccine has been got, and over 50% of the population have had 2 doses, they are trying to decrease the exposure of the population to new variants so that they can hit herd immunity. And that's where the traffic light system is coming from, because they have a clear idea based on their sequencing of where the potential variants of interest. And I've shared a number of documents with some of our colleagues, some of whom are on this program, about even the latest release from Public Health England, the technical advice that has come to some of us, to say this is why we're doing what we're doing. Ghana didn't go by that strategy. Ghana started by containment, because we didn't have the wherewithal to go looking for vaccines and all that, so that wasn't our strategy. So if we now that these variants are coming decide to go by that strategy, it will be counterproductive, because our strategy has been prevention, face masks, social distancing, sanitizing, avoidance of crowds. And that would have to be our strategy until such time that we get enough vaccines to get to the proverbial herd immunity. We cannot suddenly change the goalposts and behave like UK, which took the risk that we're going. In fact, if you look at the UK strategy critically initially, they were even looking at wild herd immunity. And so it's an entirely different strategy from the strategy that Ghana took. And therefore, if UK changes the goalposts, Ghana cannot change the goalposts to mimic the UK because they are on two different trajectories.
Yeah, I mean, very, very interesting point. Very interesting point. Sorry, let me get, Dr. Moise, you agree with that?
No, absolutely, absolutely. This is just right on point. That's exactly the way the science works. It's not a one size fits all. And I really like the point Kwame made with the UK strategy. And they could afford to do that because they have the mechanism and the system in place to change course at any time when they need to. Imagine they going for the strategy of wild herd immunity. Of course, you take a step back and we think that was completely stupid, but it wasn't exactly so. Because if it had worked in their favor, it would have been a huge savings for them in many ways, including economically. But as soon as they realized that this was heading for doom and destruction, and they were literally bottom of the pile and were at the epicenter of the pandemic at some point, this huge mechanism was able to change course, and now they are at the top of the pile. We don't have this kind of infrastructure and system in Ghana, so we can't afford to play games and change things here and there anyhow. And so exactly what he said, the strategy they adopted was quite different from our containment strategy.
So
what we need to do now, really,
at the borders, though, at the borders, we should maintain the status quo?
Well, I'll explain what we should do. Yes, maintain the status quo to a large extent. What I would say, and that's what we're already doing actually, if anyone is detected to be positive, there must be a mandatory quarantine or isolation for that matter. And this is what we're already doing as far as I know, and Abraham can correct me if I'm wrong, but as far as I know, this is what we have. The system that we have at the airport is a fairly robust system with high sensitivity and specificity. So the argument is you don't really need a particularly special eye on anybody appearing from any country because you will test everybody anyway. Unless, of course, we think the test is not sensitive or specific enough. Or so, and put it in more descriptive terms, if the holes in the sieve are too large and you are afraid that maybe some will fall through, then what you do is that you can say for everybody appearing from this country, mandatory quarantine. In fact, for several European countries, this is the case. No matter where you are arriving from, there is a 10-day mandatory quarantine. But take note, this is not quarantine in a hotel. This is quarantine at home, where they know that people will not break the rules and where there is kind of some community surveillance. We can't do this here in Ghana. It's not going to work, all right? So obviously, the best we can do is tighten that testing system at the airport, like what we're doing, make it even more stringent, more quality control checks. If anybody is positive, quarantine them, or let me put it this way, isolate them, and make sure that they're really being watched and they're tested until they're completely negative before they're allowed to enter the population. This is really our only chance, aside, of course, ramping up the vaccination as quickly as we can.
Yeah, I mean, Dr. Bediako, I want to chip in on that very briefly before I take a quick break and return and look at the impending third wave.
No, I think my colleagues are right on. I think that the only thing I would add is I think where we are failing right now is our risk communication. There is a growing complacency in Ghana. Today I was driving in Accra. Nobody was wearing a mask. I've heard Dr. Esiedu Bekwin, brother to our friend Kwame here, complaining that people are not wearing masks. In fact, I heard him say today that he's even happy that now people are talking about the new variant because maybe people will start wearing masks again. We have to emphasize that because we don't have the resources like these other countries, because we don't have access to enough vaccines, it's going to take us longer to vaccinate 20 million people. And so till we vaccinate 20 million people, life is not going to go back to normal. And Ghanaians have to embrace that. It is not easy. I understand. We all want to go back to life as normal. But from the top, from the presidency down to the school children in class, in kindergarten, everybody in Ghana has to understand that because we do not have access to vaccines like other countries, we are going to have to maintain the social distancing, the mask wearing, the so-called rudimentary public health protocols. are going to have to be enforced and maintained. We cannot be having funerals and weddings and behaving as if life has gone back to normal. I mean, look at December. We suffered through December and January because we were complacent. And now we are doing it all over again. And with Delta, believe you me, look at Uganda, okay? Delta is not a joke. If Delta explodes in Ghana, we will feel it more than we experienced in January. And so we have to maintain our discipline. That is the only thing we have. We don't have money like other countries. Our airport system is robust, but no system is foolproof. And so variants will enter. And if we do not abide by these rules, we will have a problem. And so that is the only thing I would add, is that we have to listen to the Ghana Health Service. When they say wear a mask, please wear a mask. Even if you are vaccinated, wear a mask. For most people, you're not vaccinated, so that's even a moot point. But please wear a mask. Please maintain social distancing. Gatherings, church services. I don't know what else to say. We just have to stick to these rules for as long as it takes. If it's 2022, we do it. Otherwise, more Ghanaians will suffer the consequence.
And on that note, I want to take a break. When I return, just continuing what he just been saying there, Dr. Amoisi and others have predicted that there will be a third wave. In fact, in some African countries, Zambia and elsewhere, they're experiencing that third wave. And so if you're thinking that, oh, I mean, you know, they said it, I mean, it's not going to happen. Well, we're going to return from the break. We'll deal with that. Have we missed the bullet? Have we missed the bullet when it comes to the third wave? Can we just go back to just our normal lives as has been predicted? Or something is still about to explode, as we've just heard? Stay with me. My guests, Yao, Dr. Amoisi, Kwame, and of course, Abraham, all experts in their fields. Abraham, of course, with the Ghana Health Service. I'm sure they don't mind me using their first names. I want to go back to a major point that we talked about a short few weeks ago. And I want to start with Dr. Amoisi. You had said that based on analysis and the numbers, we should expect a third wave. We're now talking about Delta. Did we dodge the bullet?
No, thanks, Evans. No, we have not dodged the bullet. Okay, the truth of the matter is, from the data that we have access to, it is clear that we are in the beginnings of a third wave of some sort. But I really want to make it clear that the manifestation of the third wave is very critical. In the UK, one could argue that they are actually in another wave of sorts, albeit maybe a fourth wave. Mm-hmm. But what's happening is that it's not going to impact on the hospitalization rates and the death rates. Mm-hmm. It's the infection rates. So what does it mean for us here if we are in a third wave? For me, it means that the risk of severe disease and ultimately hospitalization and death might be high. If you look at the numbers in the Ashanti region, it's already going up. We're doing some work, all right, for which we need to do some pre-screening. And I can tell you that over the past 2 weeks, we've seen a significant rise in the numbers of positives that we're seeing. We did a pre-screening just yesterday, and half of those we pre-screened were positive, all right? It's really interesting. And I actually told my team that just wait till next week. And it's exactly happening as I had predicted, because, you know, the science doesn't lie. It's just like, you know, it's just what it is. It will happen, all right? And it is happening. So what this means is we need to be really careful. And if you watch carefully, it's exactly the same picture. It's the younger population. It's the younger population. Because of where I sit, I get many calls from people. Oh, I'm not feeling too well, so and so and so. So you send them for testing, you find that it's positive. And then you just have to make sure that they're isolated and so on. So clearly the numbers of cases are going up. Now, it takes a long time for the infection rate to translate into severe disease and hospitalization and then to death. So you may have the rumblings now, but you will feel the full explosion much later. So it's when you have the rumblings, like right now, that you need to go full force and not wait until when the explosion happens. It's just too late. Just too late. Yeah. So really now is the time, and I really support the call by Yao, his passionate call for us to go back to the basics. That will be our only saving grace. Vaccination is not an option right now, and rightly from the data you showed, it takes more than 2 weeks for the effect of a second dose to actually kick in. We don't have the luxury of 2 weeks.
Yeah, I mean...
So really, if something's not done this week or next week, we'll be in for a rough ride.
Thankfully, Abraham is with us. Abraham, the Ghana Health Service, are we prepared for this third wave?
Thank you. I'm not privy to the data that Dr. Wesley has. But Ghana Health Service is always prepared for the worst case scenario, right? Because as a service, our duty is to protect the people. So the service
Abraham, sorry to butt in. Now we need specifics. I don't want you to say we are always prepared. I want you to tell me specifically, what are we putting in place for this anticipated third wave?
I guess we need to speak to data. We have limited resources, and the resources must always be prioritized, right? So we cannot say we observe, and that's why the surveillance system is in place, like Amos is saying. He has some privy to some data that I'm not aware of it. But the service is always prepared for third and subsequent waves.
How?
And that is why...
What is the evidence? Forgive me. What is the evidence to show that you're always prepared?
The preventive measures that have been put in place is still there, and we've been enhanced. The service is supporting all the research labs to do some of the work that they need to do. What do you call it? The education is ongoing. Obviously, there will be some lapses here and there once in a while.
Let me speak to you. Let me speak to you as. Let me stop talking to you as a journalist. Let me just talk to you as an ordinary member of the public. Everything you said doesn't inspire one bit of confidence in me that you're ready. I'm being honest with you. I mean, I'm talking to you as a journalist, just as somebody who is listening to you, who wants to get assurance from my Ghana Health Service that we are prepared for a third wave. You inspire me. Give me confidence. You haven't. I'm
giving you confidence. The last few weeks, government is making effort to get vaccines for this country, right? The education, the preventive measures that have been put in place is still ongoing. They have been enhanced. But like I've said, we need to work towards data. We need to speak to data, right? And we may or may not get third wave. It's not by force that we must always get third wave. The third wave will only come if...
But you prepare for the worst.
Your preventive measures do not work. Then you are likely probably to get a third wave. Yes, Amos might have got that data, or maybe there may be other data you are not privy to. But the service is always prepared, like I've said, and the service would take all advices that has been discussed this evening on board. And like Bediako said, maybe go back and ensure that we reinforce our risk communication on all other protocols that have been put in place, and maybe ensure that the populace are aware of the risk of the new variants coming in and the potential of the third.
Okay,
Abraham, so I think that's what I can say. Abraham, when we say we are prepared, we need to speak to the data, and we need to, if our what do you call it, our strategies are working, and we never get to the third wave.
Abraham, I have 30 seconds to wrap up. I'll give that to Dr. Kwame Sapona-Siedu. Doc, I have 30 seconds. Tell me what you made of that answer. 30 seconds strictly.
I can see John's hand up, so I'd want to cede my 30 seconds to him.
George, yes.
But what I would want to say is the data started 3 weeks ago from Southern Africa. It's gotten to Eastern Africa, and now it's gotten to Central Africa. It's only a matter of time.
John, you have 20 seconds. It's only a few, yes?
Yeah, so the data is not any special data I have. It's data from the Ghana Health Service. If you look at the numbers from Ashanti, and if you look at the news, the warnings are there from Ashanti that we're beginning to see higher cases. I was only given a special example of what we even see in our little microcosm of a study, which really reflects what already the Ghana Health Service is putting out there. So it's not any special data. It's what we all have. And as Kwame has said, it's happening elsewhere. The trajectory is the same. So we cannot say it will not happen. It is happening. But how bad it will be is what we have to watch out for. Dr.
Bediako, I borrowed 30 seconds more for you. Still on that same question.
No, I think Dr. Wesley and Kwame, you have said it. I think the wave is coming. I mean, Uganda are now on full lockdown, the whole country for 42 days, because they were recording 1,500 deaths, 1,500 cases and about 20 to 40 deaths a day. Western Kenya is on lockdown. So, we have seen that Delta has arrived at our airport.
So I guess there's consensus. I guess there's consensus. But when you hear the GHS say,
no, I don't think. I think the problem, like I said before, we should not beat up. I want to come to Abraham's defense here. The GHS is doing their best to control the situation.
Okay.
But Ghanaians in general have to take responsibility. GHS is not going to come and force you to wear a mask.
Okay.
It is you as a citizen who has to wear your mask.
Perfect.
And I think that is what has to happen.
Perfect note to end this. Enjoy the rest of your evening. Pay attention. The word to the wise is here. Yeah.